Have you guys been using these two drugs? Have you been using fostemsavir or ibalizumab?
Yeah,
Well, I
said,
mentioned I have
said
my
we have a patient, congenitally infected individual. He's in his mid-20s, resistant to all available drugs, failing clinically. You know, CD4 below 100, complications of AIDS, and he's now on both of these drugs, and as part of their clinical trials.
Yeah, and we have a couple of people on the trial with fostemsavir. One is a woman who really had kind of crazy beliefs about how to take her medicine, and also was stuck on zidovudine. And I think it was intolerable for her, but for whatever reason, she finally got referred to us. She's on fostemsavir, she's off zidovudine, and she's suppressed. But one reason why she's suppressed is she has a study coordinator that literally calls her every week and says, "Have you taken your pills this week?" And over the Christmas holidays, she came in early January with a detectable viral load because, you know, she didn't get a phone call saying over the holidays. But it does work. It definitely.
So you
works.
see this, both of these drugs, one of these drugs, the other drug, as part of your armamentarium for
I think so. I think, and I think, you know, again, we do. In clinic, we had exactly one of these young ladies that Paul was talking about, someone who's, you know, been through so many regimens as a teenager. I mean, trying to get teenagers to do anything, you know, brush their teeth, you know, dress appropriately. It's tough to get adolescents to do anything, and then they're HIV infected. They have all that emotional and psychological baggage, and they can have really resistant virus.
And these are the folks, right, you were just pointing that out.
That's right.
These are the folks with resistant virus. And in fact, as the population ages, right, the initial wave, you've got controlled, and now we've got the congenitally acquired folks who are resistant, that cohort.
That cohort will
cohort's
continue
resistant.
until they get suppressed.
Right, and the other thing about it is
live
it's
forever
not
or
like
don't.
if they go on the attachment inhibitor, fostemsavir, and it works, then they got to stay on it, right? It's not like there's going to be a replacement anytime soon.
So what you're saying is if we control transmission at childbirth, then we've got this cohort that has it.
Right.
They're resistant.
Right.
They're going to need something like fostemsavir or something like that.
And I do have, and you know, I'm sure actually all of us are probably the same way. I do have patients where I know that underneath the surface of the water, they have a lot of resistance. And when they come in and I get their viral load, I wait for that viral load. And I think, God, if their viral load is up, I don't know exactly what I'm going to do.
Usually it's because they had a hiatus in their therapy, fortunately.
Right,
It's very rarely that they've now developed dolutegravir resistance.
But
it can happen.
But you can.
It can happen.
You can worry about that.
No,
Well, maybe I shouldn't.
Yeah,
I should stop worrying.
No, I would worry.
Keep worrying.
I mean, I do worry. I mean, we had someone who inadvertently through one of, you know, when prescriptions are refilled, they're not always refilled properly, and someone who was on twice daily dolutegravir because he needed twice daily dolutegravir, he had a lot of integrase resistance, was given it once daily, you know, and he had virologic rebound. Fortunately, he did not have selection of new integrase resistance. Now he's back on twice daily dolutegravir and infevoritide. Yeah, and so he's suppressed again. But that is yeah.
But again, it's one patient a month that one of us might worry about, not 3 patients a day.
Yeah.
So it is a small population.
Now there are some other